To close our program, we are honored to welcome another of our region's most outspoken advocates for comprehensive solutions to the opioid epidemic, the Honorable Governor of this great state, Massachusetts. As all of you are aware, he took office in January at a time when our Commonwealth was facing a variety of crises, the opioid crisis being just one of many. Within weeks of taking office, he convened a multidisciplinary opioid addiction working group, and the task was to formulate a statewide strategy to combat addiction. In June, that working group delivered a very comprehensive report detailing 65 actionable steps to curb the crisis that we have been experiencing here. He's put it into a comprehensive piece of legislation that I believe he just introduced a few weeks ago, and I'm told that the district attorneys of the Commonwealth have endorsed this piece of legislation. So we're delighted that he could join us this morning to cap off what has been a incredibly informative and thoughtful discussion of this issue. Please join me in giving a very warm welcome to the Governor of the Commonwealth of Massachusetts, our good friend, the former chairman of the New England Council Board, Honorable Charlie Baker.
So you're just never going to let me live that one down. Is that the way it's going to work? Okay, just checking. No, it's good. Well, thank you very much, Jim, and thank you for giving me a chance to chat with you all today about this hugely important topic. Jim, you mentioned our task force, which I appreciate. Commissioner Burrell was on that task force, and Steve Tolman, who's sitting right next to you, is also on that task force from the AFL-CIO. They did a terrific piece of work. They had 4 or 5 hearings around the Commonwealth. They probably heard from 1,000 people. And I sat through the session they had in Boston, and the Attorney General was actually deeply involved in this as well. And the overwhelming sentiment that came out of it was what I would call sort of 4 parts. One was we need to do a much better job on prevention and education. We need to do a much better job on intervention, and we need to do a much better job on treatment and recovery. And the report itself is available in a lot of places. I think all you probably have to do is Google it and you'll find it. But that report is mostly just about people, okay? This is an issue that I certainly didn't run for governor expecting to spend a lot of time talking about, but it was one of those things that just came up everywhere I went. If there was a room that had more than 10 people in it, somebody was talking to me about this. And I didn't have to bring it up, it just showed up. And the stories that people told were incredibly personal and in many cases tragic. And it really didn't matter where I was. I mean, I could be in Eastern Mass, Western Mass, Southeastern Mass, and it didn't matter what community I was in, and it didn't matter what the crowd was. It became very clear to me that this was something that literally just ran the gamut from one end of the Commonwealth to the other. And I know the governor of New Hampshire was here earlier today, Maggie Hassan. She and I have talked about this. In fact, all the New England governors have talked about this. And Governor Shumlin up in Vermont made this issue his the core focus of his State of the State address several years ago. And I guess what I would start by saying is that while there is certainly a lot more conversation going on about this than there was a few years ago, and there seems to be a lot more appetite to engage the discussion, I've never seen an issue that has more negative momentum than this one does, and it's going to require an enormous amount of effort to kind of break that trajectory. There were about 500 people in Massachusetts who died of an opioid overdose in 2006. Last year, there were around 1,400. More than died of automobile accidents and gunshots put together. And more than died, by the way, from Massachusetts through the entire history of the Vietnam War. And yet, this is still an issue that I run into people all the time on who don't understand my sense of urgency, my sense of concern about the fact that today is going to be tomorrow and then tomorrow is going to be the next day, and we really need to be moving a lot more aggressively on this. And I'll tell you something, the other interesting thing about it is there's a debate, a healthy debate going on in the healthcare world, and I'm a healthcare guy, okay? So I take that part of it pretty seriously. And I was surprised to learn that it's not that hard to graduate from medical school without ever taking a course in opioids or pain management or addiction. That in fact, most people graduate from medical school having never done it, and that it's not considered to be sort of a required core competency for anybody who graduates from medical school. The same thing goes with dental school. And when we took a look at the folks who currently serve on the boards of registration of medicine, dentistry, nursing, and all the rest, there's one who who had a background in addiction. And there are no, at least at this point in time, mandatory continuing education requirements around addiction and pain management, at least in Massachusetts. And there really isn't any sort of core curriculum for middle school and high school kids. And those are big parts of what have been in a number of pieces of legislation or funding documents that we've put forth working with the legislature over the course of the past year or so, all driven by the recommendations that came out of that task force report. And some of it we're making some progress on. We do have, for the first time, the ability to develop curriculum and encourage communities to adopt it. We do have a much more robust set of mechanisms in place to support and finance treatment and recovery, but we have a long way to go on this. And the legislation that we filed several weeks ago, which is actually going to be heard on November 18th in front of the Substance Abuse and Mental Health Committee, has a number of key elements, but I'll just give you a couple of them. One of them would limit first prescriptions to 72 hours. All first prescriptions to 72 hours. Now, we can debate whether it should be 72 hours or 114 hours or 3 days, 5 days, 6 days. I'm perfectly happy to have that conversation. But there are still far too many people who are getting 30, 60, and 90-day prescriptions for wisdom teeth, broken fingers, sprained ankles, stuff like that. And there's simply no medical positive justification for it, and there are enormous negative clinical reasons why you shouldn't do it. But it still happens, and it happens a lot. In Massachusetts last year, and we consider ourselves to be a conservative practicing community, okay? In Massachusetts last year, there were 4.4 million, you may have already said this, Commissioner, and I apologize if I'm repeating it, but some things deserve to be repeated. 4.4 million Schedule II and Schedule III prescriptions written in Massachusetts, which are basically benzodiazepines and opioids. 85% of those are opioids. That translates into 240 million pills in the Commonwealth in 1 year, in what's considered to be a conservative practice environment for a state that has 6 million people, most of whom were not sick last year. The numbers on this stuff are extraordinary, and we won't solve this problem simply by thinking about it as a heroin issue, because it's not, and I don't talk about it that way. It's an opioid issue, and for the vast majority of the people who end up addicted to heroin, they began through a prescription pain medication, a pain medication prescription. There was a story in the New York Times yesterday. It was written by Richard Friedman, who is the director of the psychopharmacology clinic at the Weill Cornell Medical School, is a professor of clinical psychiatry. It's called How Doctors Help Drive the Addiction Crisis. This won't make me any friends among my colleagues in the healthcare community, and I get that. But there's some very interesting statistics in this. First one was that the rate of death from opioid overdoses, prescription opioids, between 1999 and 2010 went up fourfold, which was faster than the combined number of deaths increase from heroin and cocaine put together. In 2013, opioids were involved in 37% of all fatal drug overdoses. Substance Abuse Mental Health Administration has said that 4 out of 5 heroin users got started on prescription pain meds. And the medical use of opioids generally went up 1,000% between 1995 and 2015. We represent 5% of the world's population. We consume 80% of the world's opioids. So when I start talking about limiting first prescriptions to a few days, because there's a big difference between acute pain and chronic pain, I find it interesting that people consider that to be a controversial proposal. And I want to tell you how much I give credit to the folks at Partners who had a letter published in the Boston Globe today from 3 of the leaders of the physicians organization at Mass General, who basically said why they might quibble on the margin with some of the proposals that we made with respect to prescription drugs. Generally speaking, they think directionally we're heading the right way. And the example I've used when I've talked about this is when I got to Harvard Pilgrim, it was going at like 180 miles an hour straight into the ground. And I said to the people who were there, well, what should we do to fix it? And they gave me a bunch of recommendations that would have moved the thing a little bit on the margin. And I said to them at one point, you know, if I implemented everything you just gave me, we would hit the ground 10 seconds later than we would have hit it otherwise. But in terms of actually changing the trajectory, it's just not there. This requires disruption. Disruption. If we just bend the, I don't want to be dealing with this issue where we're all talking about success because the number of deaths, instead of going up 25% next year, only goes up 22%. Or the number of overdoses only went up, 30% instead of 33%. And that means you have to chase this with some proposals and some ideas that are controversial. But at the same time, that's how you engage a discussion and a dialogue, and that's how you get people to start thinking differently about whether or not the status quo should be allowed to stand. Now, I commend the New England Council for hosting this today because it's really important that people in the public domain engage this conversation at all levels. I had met with a group of sheriffs this morning because many of the sheriffs will tell you that 40 to 80% of the people in Massachusetts who end up in their facilities for a conviction are there because they're addicted to drugs or alcohol. And several of them said more than 50% of the people that they detox, they're detoxing off an opioid. But one of them also said to me that while he was in that meeting, there was a funeral starting for the son of one of his employees who died of an opioid overdose on Friday. I don't want to be the governor who ends up presiding over 2,500 opioid deaths, or 3,000 in 1 year, or 3,500. Especially when there are things that can be done to deal with this. Now, we're working hard with the legislature and with our colleagues in other states on a number of initiatives to deal with this. And I fully expect that many of them will come to fruition. Probably won't happen as fast as I would like, but I believe everybody's pulling in the same direction on this.